So as I say, I wanted to also talk to you about the importance of the timing of antiretroviral therapy in HIV-associated cryptococcal meningitis, because it's very clear that if antiretroviral therapy is started too soon, then the patients are at increased risk of severe immune reconstitution reactions, and they have increased mortality, as shown here on this graph from the results from the COAT study led by David Boulware and colleagues. And so the current recommendation is that in antiretroviral naive patients with cryptococcal meningitis, the ART should be started between 4 to 6 weeks after starting antifungal therapy. The kind of exception to this is in unmasking cases of cryptococcal iris, so-called unmasking cases, where cryptococcal meningitis presents for the first time, usually early after the start of antiretroviral therapy. And in that case, in those cases, the antiretroviral therapy should be continued. And then finally, there's an increasingly important group. These are patients who have had antiretroviral experience, but are still presenting later with cryptococcal meningitis with low CD4 counts, either due to problems of adherence to antiretroviral therapy or because they're failing antiretroviral therapy due to resistance. And in those cases, I think it's wise to defer the restart of antiretroviral therapy or switching to second-line antiretroviral therapy in the case of resistance. Those should be also deferred until 4 weeks